research workforce by enabling these researchers to bring in historically underrepresented and other types of groups of trainees from the high school students level all the way up to the early stage faculty to do some projects that's related to the main funded grant. And it provides salary support for these trainees to work at UCSF. And we have a program that's set up around this. We have a matchmaking event. This one, the November 22nd one, is 11 o'clock for faculties. If you have a grant that might be eligible for diversity supplement, that's basically all the R's except R21s, I believe, and the P's, U's, all of that. We encourage you to get the info session to learn about how to meet new trainees. And there is also one for trainees. So if you're from a historically underrepresented background and interested in matchmaking, there's one on the same day that's earlier. You just go to the website justice.ucsf.edu to get more information about how to register. And then the matchmaking event actually occurs later in the year where you can actually meet people and decide whether or not you're appropriate fit. Email Erica Wong at ucsf.edu for more questions. I mentioned this earlier. We use this intentionally as a mechanism to diversify our training workforce. And the reason why to show this is, number one, that we are getting more and more of these submitted and awarded. And the key thing to look here, besides the dollars, is the success rate. So typically when you apply to the NIH, the success rate is like 10, 15, 18, 20%. We have managed for the diversity supplements to do really well. We're over 50%. So if you can get a match with your faculty and you submit it, there's a pretty good chance that you'll get funding. So, it's money to do the work and to do the learning, but also it looks good on your grant. You actually get an NIH diversity supplement, right? So it's all good for the trainees and also the faculty. And we wanted to recognize our faculty who's done such a great job. That those numbers were not done by any of us. It's a lot of these faculty. So here are the list of the faculty at UCSF who got at least one NIH diversity supplements in the last 24 years. And if any of you are here in the room, would you like to speak up? Not speak up, but stand up so we can recognize you? Yay. Oh, there you are. Okay. And then we did have, we sort of made up this award, but we thought, we like to give out awards. So for those who've gotten 3 or more diversity supplements, so these are the real people who are just basically getting one every year. This is our list, starting with Joe Palevsky, who basically looks like he's gotten $1.5 million for trainees all on his own. And then Aparna Lakaraju, Erin Van Bergen, Yvonne Yu, Alan Basbaum, Jeffrey Manley, Todd Neistel, Guo Huang, John Karanowicz, Rita Hamad, Vijay Namboduri, Susie Lee, and Bruce Miller. And for them, you want to hold up in the back there, we have a little certificate. And if you're here and you're one of those people, come to the back and we'll give it to you. Otherwise, we'll make sure we get to them. Thanks.
Well, first of all, thanks to all of you who made the decision to stay the afternoon and stay for some boba and stay for these wonderful presentations. I'm Dr. Vic Fujimoto, Department of OBGYN, and I'll be the moderator for this particular session. I'm excited to introduce our plenary presenters in this third block, and they're as follows. We have Jacqueline Odiase. Is that correct? Yeah. And Andrea Jackson, title is Embrace Race, Concordant Perinatal Care for Black Families, Reclaiming Health and Wellness for Black Births. We have, followed by that, Andrea Quiñones-Rivera, Impact of Racism and Bias on Patient Experiences of Social Care, Implications for Implementation of Healthcare-Based Social Care Interventions. Third, we have Sofia Weiss-Goitiandia, understanding and addressing the impact of structural racism on serious illness care for older Black adults. And then finally, we'll end with Gabby Negussie-Retta, and the title of that presentation is Implementation and Evaluation of an Anti-Oppression Education Plan in Medical School Curriculum. Please give a warm welcome to Jacqueline and Andrea.
And to advance, this one right here. Great, thank you. We should probably introduce ourselves. Yes, all right, great. Good afternoon, my name's Andrea Jackson. I'm an obstetrician gynecologist. I'm chair of the OBGYN department here at UCSF and co-founder of Embrace.
Hello everyone, my name is Jacqueline Odiase and I'm a research and evaluation manager as well as research data analyst at OBGYN.
And we're part of the evaluation team for Embrace. Very happy to be here. So we introduced ourselves. There's also Dr. Patience Afolani, who rounds out our evaluation team as well too. And getting right into it, in the United States, we have a Black maternal health crisis. Nationally, Black women are 3 to 4 times more likely to die during pregnancy or during the postpartum period. They're more likely to experience preterm birth, that is a pregnancy before 37 weeks, and more likely to experience inadequate pain control during labor and healing, and more likely to have unnecessary C-sections. What we know so far, what the evidence tells us, is that more than 80% of those deaths are preventable. Most of these outcomes are linked not to race, but to racism, and how Black birthing people and their families are treated throughout their prenatal care, and their lived experiences and daily stressors of going through their lives as racialized people in this country. Like I said before, there's a Black maternal health crisis, there's structural and institutional racism and discrimination across the life course that we believe are the root causes of these inequalities. So the answer, in 2018, I still am a practicing OBGYN, but to be honest with you, I became very frustrated with this narrative. And so myself, along with a midwife, Melinda Fowler, and a licensed clinical social worker, we came up with Embrace as a solution. Embrace is a perinatal care program that incorporates evidence-based care and the wisdom of the African American community to provide racially responsive care. Specifically, and this I don't think is on these slides, but it provides group prenatal care, a model that was developed by midwives back in the 90s, integrated with both group and individual therapy provided by licensed clinical social workers up to 1 year postpartum. And this is very important because the definition of maternal morbidity and mortality actually extends up to 1 year postpartum, and the vast majority of the deaths that occur happen in the postpartum period, not when they're pregnant or giving birth. All of this is delivered by racially concordant clinicians, providers, and staff. There are 8 pillars to Embrace, 8 core components. In the interest of time, I will not read off, in detail all of them, but just to give you a quick flavor. The first pillar is a racially responsive framework and curriculum. We do not hide or skirt around the issue of racism. We talk about that during our small group sessions with patients. The second is, as I said before, is a racially concordant program. So all of our providers, all of our staff, and facilitated, and our guest speakers as well too, are racially concordant, so they're all Black identifying. We integrate mental health services. So like I said, they get group therapy, and they also get one-on-one therapy as well too. The fourth pillar is patient-driven communication and care delivery. The fifth is integration of the village. What we found out very early on is that in order to do this work, it couldn't just be taking care of the birthing person, it was also taking care of the family. So a lot of the work we do is actually family work as well too. There's extension into the postpartum, so that's the other pillar, like I said before, up to 1 year. Our goal is safe passageway for our birthing participants and babies. And last but certainly not least, and we won't, I don't think, talk about it too much, well, we will talk about it today, is soul care. So specifically caring for the provider. Anybody who does this work know that burnout is really high. And so we learned very early on in our work that we had to incorporate taking care of the providers in the work that we do. Hand over to Jackie. Yeah.
Now I'll briefly discuss our methodology. So our evaluation objectives was to assess the effect of Embrace on participants' experience of care, as well as the impact on their birth outcomes and postpartum health, and finally, the impact of the program on providers' well-being and experiences. So our target population consists of Black pregnant and postpartum individuals, as well as Black perinatal and mental health providers delivering care in the program. For the participants, we administered surveys at 3 time points: baseline, which is administered upon enrollment in the program. This assesses their experiences at their usual sources of care. Then a midline assessment at 3rd trimester, which assesses their experiences in the Embrace program. And then a final assessment 3 months postpartum, which assesses their overall experience at Embrace. And we've also interviewed a subset of the participants and interviewed the providers as well. For the sake of time, I will only discuss the findings for the participants. So this is demographics for the baseline sample. So the mean age is 32 years of age. 50% of the sample have at least a college degree. We see a wide range in terms of monthly income, about equal distribution in terms of employment status, and about 27% have indicated some level of food insecurity. So when we asked how acceptable the program is to them, nearly everyone found it to be highly acceptable, and they attributed to feeling comfortable with their providers, as well as the inclusive nature of the program, particularly with respect to the perinatal groups. As this participant said, I expected it to be like a community of all women, but this time it was with the dads, which was cool because we got to hear their perspectives on something that is usually always a safe space for women, usually not the father. So that was cool. And another one was the accommodation of the providers and the program at large. The fact that providers are willing to meet these women where they're at. As this participant said, I've also gotten lactation consultants through the program. They came into my home, which was more than what I was expecting. So we also probed about the accessibility of the program. And so what some of the notable facilitators was the reminders and follow-ups that they received from the providers and administration, as well as the providers going above and beyond to meet their needs. As this participant said, they even helped me get transferred for my children. UCSF wasn't taking patients at the time, but my provider was able to pull strings and get me in. However, there were notable barriers as well. One was participants had difficulty knowing about how to get into the program. As this participant said, I really did want the Black doctor, the Black midwife. I didn't realize that you could pick Black practitioners. I also just had no idea how to do that. I would take the flyer and I would see all the Black doctors and the flyer in the picture, but I had no idea how to get to Black doctors on the flyers, and I had that flyer in my car for months. And another barrier is that once they entered into the program, some participants had difficulty knowing about the full range of services that were available to them. So when we look at person-centered care, the baseline here score is 78.4. So this is how they perceive care that they receive at the usual sources of care, but in comparison at Embrace, it is 91.5 out of 100, which indicates that Embrace is significantly more person-centered care than where they usually get services. And this is supported by our qualitative findings, as people attributed the high person-centered care to the responsive nature of the providers. Just for time, I'll just summarize. This participant had an incident with the SFMTA operator, and her provider wrote a letter and some other supporting documentation so she can submit a claim against the city. The provider, in addition, continued to follow up with the participant to make sure that the case was moving according to plan. Another reason why participants rated high person-centered care from Embrace providers was because they felt supported. And in this terms of support, is just listening to them. Simple, but it's very powerful. And in moving to trust, we see that the mean standardized score here was 67.5 out of 100, where they usually get care, in comparison to Embrace, which was 91.6 out of 100, again suggesting that Embrace is significantly more trustworthy than they usually get services. And moving to racism discrimination, I do want to preface that the higher the score is here, the more experiences of racism discrimination that one reports. So at the usual source of care, it's 35.4 out of 100. But if you look at Embrace, it is only 0.8 out of 100. So practically no racism and discrimination experiences. And again, this is supported by our qualitative exploration. We asked participants, how do they feel about receiving race concordant care? Nearly everyone had very high perceptions of receiving this type of care. And they attributed to the positive impact it's had on their birthing experience. As this participant said, I went to triage and I was seen by a provider who was not the same race as me. And she kind of dismissed my concerns. She kind of brushed it off to be not my water breaking and being something else. In that same moment, one of my Embrace providers came in and checked me, and it was my water breaking. So just in that alone, like if she hadn't come and checked, I would have been sent home, and there would have been a whole different situation trying to bring my son into the world. And another reason why people had high perceptions of race concordant care, particularly through Embrace, is they felt protected by their provider. As this individual said, my provider told me, I'm glad you're here, and I'll be your guardian angel today. And just like that, the participant started to feel better. Her provider continued to say, I'm here for you, let me just focus on you, let's breathe together until we can get it. So in closing, our findings suggest that Embrace is highly acceptable, it's highly person-centered, it is highly trustworthy, and it does reduce experiences of racism and discrimination, and it has great potential to improve perinatal outcomes, particularly for Black birthing people. However, this is a preliminary stage, and our evaluation is ongoing, so we are trying to obtain a larger sample size to better support our conclusions. Thank you for listening.
Okay, let's see. Next up is Andrea Quiñones-Rivera. Just hit the button forward.
That's forward.
There you go.
Hey guys, I'm Andy. I'm a research fellow with NCSP, and I'm part of the Department of Emergency Medicine. I'm going to be presenting on a qualitative study that we did on the impacts of racism and bias on patients' experiences of social care. All right, so first some background. We know minoritized communities bear the brunt of inequities in health outcomes and social needs. And social needs here are defined as things like housing insecurity, food insecurity, transportation needs. And as such, healthcare systems have been increasingly interested in addressing social needs as a strategy to address health inequities. And we've all been seeing this in our practices. Screening for social needs has become more routine, and we're seeing more and more interventions geared at patients' part of healthcare. So when we talk about healthcare-based social care, we're talking about screening interventions or related activities that take place in healthcare settings, and the resulting referrals, resources, and interventions that come from patients disclosing that they have certain social needs. What's interesting is that even though this is becoming more of a part of patients' healthcare, there's sparse literature on what patients' experiences are of social needs care in healthcare, and even fewer studies on the experiences of minoritized patients with healthcare-based social care. And so what we tried to do was we did a study to understand the role that race, racism, and bias may play in patients' experiences of healthcare-based social care. Sorry, I didn't realize I wasn't speaking into the microphone. So we conducted a qualitative study of 25 semi-structured patient interviews and really just asked patients who had adults who had experienced healthcare-based social care in the last 12 months about how it felt to be screened. How did it feel to answer these questions? Did they feel like they could answer honestly? Did they feel like their race, gender played a role in their experience of healthcare-based social care? And we included participants that were from racial, ethnic, minoritized communities. We double-coded the interviews and conducted a thematic analysis. So these were our participants, these were our patients. We had 9 Black or African American participants, 16 Latinx participants, and about half of our patients were monolingual Spanish speakers. We had folks from a range of cities across the United States, and most of our participants shared their experiences in outpatient settings and primary care. So what did we find? This is the too long, didn't read. Essentially, we found that systemic, structural, and interpersonal racism were really important factors in our participants' experiences of healthcare-based social care. And going a little bit deeper into this, we found that participants talked about distrust, how that distrust is transferred from their experiences with medical care to social care, how this distrust led them to disengage from healthcare-based social care, and participants also described things and factors of their social care interventions that promoted trust. And a lot of the distrust that folks are really feeling had to do with stigmatizing narratives around race, poverty, welfare, and government services. And so just going a little bit deeper into each of these themes, this participant describes being really hesitant while she was being screened in her first primary care visit. She says, "I'm a new patient. I've never met this person. I'm filling out all this information. Am I going to be judged by this?" And we heard this phrase said over and over again. "I didn't want to be another stereotype. Another Black woman, she got kids she can't take care of." We heard this over and over again where people were really hesitant to answer questions for fear of being judged by their provider or their social care provider. We also saw that when we asked participants about their distrust or their trust in healthcare-based social care, they gave us examples of their experiences with medical care. And so in this case, this participant says, "My last experience with social needs screening was when I had a baby. Immediately, they wanted to do surgery to tie my tubes. They lectured me. You don't work, and your husband has 2 jobs. You end up casually sharing things, but in the end, they use that to attack you." And with this frame of mind, participants also describe disengaging from healthcare-based social care because of these experiences, in that they would withhold actual social needs during screening encounters or decline offered services for social needs that they disclose for fear of what would happen next. And just overall disengaging from social care. And going a little bit deeper here, this participant says, "The question with this initial social worker, it was very biased. The way she would ask the questions, I said, well, I think I'm good. I don't think I want to answer more questions. She just wasn't sensitive." And then this participant describes disclosing a social need and then declining offered services for it. She says, "When the social worker was called in, the first thing I felt was fear. I was thinking, they'll take my children away from me. They'll say I have postpartum depression or something. I was so afraid that I took the pain medication and I never went back." And we also saw, and we also heard from participants that had positive experiences, that things like racial and cultural concordance with their social care provider, whether that was the primary care doctor, the community health worker, whoever was doing the screening or the interventions, was really important. Language concordance and cultural humility. This participant says, "You do feel uncomfortable. You're asking me a lot of personal questions, and in the back of my mind, I think, you're not where I'm from. You're not going to understand what I'm going through." And on the flip side, another participant said, "I feel very comfortable. There's a lot of staff and personnel that identified, look like me, that sort of thing." And this participant says, the first social worker, had me feeling like I was just some welfare case off the street. The second lady was a Hispanic lady. She was just a lot more culturally sensitive. I do feel like she was being respectful of my culture, and it was a gleamingly different experience. And so what does this mean? What do we do with all of this in the interventions that we see day in and day out in our clinical settings? What we know from this and from our results is that racism deeply impacts participants' experience, patients' experiences with social care, and that we in healthcare are not starting with a clean slate in our social care delivery. We bring in a lot of history. And so without attention to racism's roles in patient experiences, our interventions really do risk further entrenching distrust. And we heard from participants that, they disengage if they sense that there's a reason to distrust or they sense that they're being judged. And this has implications for whether they disclose actual social needs or whether they actually accept resources that are offered. And that has an impact on the accuracy of the screening and referral rates that we like to put up in our research and evaluation. And when we think about the expansion of social care metrics throughout insurance spaces and healthcare systems, this has implications for that too, as well as if folks aren't engaging in social care, it may not work and it may limit their use as health equity tools. But I really want to ground this home because we're going to be seeing a lot of this data pop up in the next few years around CMS and the quality metrics related to social care activities in different healthcare institutions. So starting this year, CMS requires hospitals to report on the percent of hospitalized patients that they screen for 5 healthcare-related social needs, and also report on the percentage of patients that screen positive. So let's say let's say this is an example of San Francisco General, and these rates are pretty close. But let's say 70% of their patients are screened, of their hospitalized patients are screened for healthcare-related social needs. And 1 month, 30% screen positive, another month or another year, 50% or 20% screen positive for health-related social needs. What does this mean? What does this mean if San Francisco General's patient population is something like 60 or 70% Black and or Latinx? What this shows and what our study really points to is a need to sort of dig deeper and look past some of these volume-based metrics and really take into account patient experiences of care. Here's my acknowledgements. Oh, thank you.
Our next speaker is Sofia Weiss-Goitiandia, and the title is, whoops. I guess this is the next slide. Understanding it, is that correct? Is that your first slide, or is this?
These were supposed to be deleted from
Oh,
my presentation.
sorry.
So keep going.
Got it. Oh,
going.
okay, keep going.
There it is.
Huh? Okay, I didn't realize I was supposed to finish her talk for her, actually. Anyways, next, so here's our title slide here. Okay, understanding and addressing the impact of structural racism on serious illness care for older Black adults. Please welcome.
Hi, I'm Sophia. I'm just going to make sure that I understand how the clicker works. Okay. And I'm presenting this talk, which is called Understanding and Addressing the Impact of Structural Racism on Serious Illness Care for Older Black Adults. And this is part of a research project I've been conducting as part of Dr. Liz Zeng's research team in the Division of Hospital Medicine. And I really want to start by shouting out everyone on the screen. That's the research team and the Community Advisory Board. I am really just like a needle in a haystack here. Okay, so why this project? Well, what we know is that older Black adults experience several inequities in serious illness care. So they're more likely to experience inadequate pain management, and they're less likely to access high-quality hospice, palliative care, and serious illness care services. And when thinking about this, we wanted to look beyond individual care encounters as the source of racial health inequities in serious illness care and turn to thinking about structural racism as a cause behind these inequities. And structural racism is defined as the ways in which mutually reinforcing systems woven into laws, policies, and institutions result and perpetuate racial discrimination. So a little bit about our orientation toward studying structural racism, which rests on 3 main pillars. So this is an oral history-based qualitative interview study, and we use a structural life course perspective to elicit and connect experiences of structural racism throughout the life course to perceptions and experiences of serious illness care later on in life. We also draw on public health critical race praxis, primarily to encourage race-conscious reflexivity throughout our research process, and we leverage a community-based approach, which you can see here. This is us having lunch with our amazing community advisory board, who are this wonderful group of folks who've supported us from the start. Insofar as possible within a large institution, we aim to engage them as equal partners in this research, and it's 9 older Black folks from across the Bay Area. We're also trying to be accountable to our community in conducting this research. We have several community partners, and I will circle back to that at the end. So briefly on our methods, as I said, this is an oral history qualitative interview-based study. We're conducting interviews with older Black adults aged 55 and over who have some diagnosis under a broadly construed umbrella of chronic and serious illness, and we're using a pluralistic qualitative analysis approach incorporating thematic and narrative analysis. This is a lot of info, so I'm just going to break it down a little bit. We've so far interviewed 13 older Black adults, ages 54 to 77, mix of self-identified men and women from across the Bay Area, with lots of different diagnoses of chronic and serious illness, as well as differing illness stages. And to get to kind of the meat on the bone, these preliminary themes are in development still because we're conducting additional interviews, but we thought we'd share them with you today to get some of your thoughts. So the first theme centered on the financialization of healthcare and experiences that connected affordability of care, insurance status, and retirement funds as challenges faced by older Black adults in accessing serious illness care. So I have a quotation here. To get my knee x-rayed would have cost me $300. I didn't have it. From an acting job, I was just able to pay my phone bill, which is $136. I'm juggling balls with my health and being able to get gainfully employed, because then I can get the medical coverage. But I'm going to face various challenges because I fetch $65 to $90 an hour for my chef skills. The gut punch is to switch careers because my body couldn't handle the rigors of being a chef. I've had to re-educate myself, which I'm grateful for. But the starting gig for this is, and I've got the credentials, $19. That is a precipitous drop. So a lot of our participants shared experiences like this, experiences of having experienced either limited economic opportunity across the life course or economic setbacks. For many folks, these experiences worsened as they got older and could no longer work. And once they could no longer work, for many people, they had no safety net on which to fall back on. One particularly interesting aspect of this experience is that many folks expressed that they had retirement savings, but that for unexpected costs had had to use them before they could even reach retirement. And so for many folks, like this participant, that left them in this position of having to choose between, do I pay for what I need now to survive, to get through to next month, or do I pay for healthcare? And for many individuals, very understandably, sometimes this meant forgoing healthcare. The next theme relates to social identity and learned dynamics, which links back to some of the social stereotypes in particular that Andy talked about. So this quotation, when you talk to me, you guys need to be on the same page. Clarity, effective communication, point blank here. I won't accept nothing less. And so I get proactive. I don't want to say angry because, sometimes I get a little excited when I talk, and I want you to feel me when I talk. I want you to understand the words that are coming out of my mind, because if I don't, then I don't feel like you're really hearing me. But that's dangerous as a Black woman. So many of our participants shared experiences that we sort of theorize as a kind of double consciousness, where even when they were sick and vulnerable, they were having to come into their providers feeling that they had to engage in some kind of reputation management to prevent activating stereotypes that might lead to discriminatory care. As one of our participants put this is the result of a healthcare system created by white people for white people, and that therefore had a limited understanding and tolerance for people from other racial and ethnic groups and different ways of being in the world. Our third theme relates to resilience and trauma. And this quotation for you. I got bit by a brown recluse spider. They didn't want to send me to the doctor. I said, but I need to see a doctor. So I went in to see the doctor and he gave me some antibiotics. The whole atmosphere wasn't overly welcoming. And I watched the posture of other Black people coming in there. I'm talking more direct than them. I see it now, but I didn't totally understand it. I started taking these antibiotics. I get here to San Francisco. My medication was outdated, and I wind up hospitalized for 6 to 7 days. We talk a lot about lack of trust, or the literature talks a lot about lack of trustworthiness experienced by Black folks in the healthcare system, but this isn't limited to the large-scale examples of institutional betrayal that we often think about, things like Tuskegee. For many folks, this is part and parcel of their healthcare experiences. It accumulates across the life course, and as seen in our quotation, it can be passed down throughout generations. Critically, as reflected upon by our participants, this can have a big impact on how people show up and the expectations and fears that they have for care later in life. And our final preliminary theme is about the intersection of race and socioeconomic status. One of our participants said, "We're constantly thinking about our future, for land and opportunity, retirement, our parents, property, housing. We're trying to deal with what's in front of us. When they told me I had liver disease and the kidney disease has gotten really bad, I'm like, okay, well, so when does this go away? We pay for the medication. Well, this isn't going to go away. I have a will. I'm trying to get all that paperwork together and get some insurance that won't cancel because of healthcare. Get that to cover some of my final expenses. When my brother died, he didn't have anything, and it was a horrible shock. And my parents didn't have money. I don't want that for my family." This is an individualized experience, but it spoke to something that came up commonly across our interviews. People came from, for example, middle-class working families that due to barriers like struggles to transfer money into property ownership had struggled to turn their money into assets and critically also to pass those assets down to their children. That created complications, as we see for this participant. When they got really sick, they're dealing with their own healthcare issues and needs. Their mind is in the future. How am I going to support my family to support my healthcare? And how am I going to prepare for my potential passing and reduce the financial burden upon my family? And to us, this shows how structural injustices in areas of life that seem quite far initially from healthcare and that might even affect families rather than individuals actually can have a pretty big effect on people's serious illness experiences. So to wrap up, I think the key takeaway is thankfully something that we've heard a lot today, that social determinants of health don't appear out of nowhere. One of their key root causes, we think, is structural racism, and therefore the gap we're trying to close is that when we're trying to reduce racial health inequities and inequitable social determinants of health, we need to think about intervening upon structural racism. And that's something that we're trying to do by using our data to inform existing and future interventions that target sort of modifiable targets within the healthcare system and structural and serious illness care. And the final community-based piece is that we work with this amazing group, and we're hosting an event in April on health justice at UC Law. So sign up it's a theater event, it's a performance event. Sign up if you want more details, and thank you very much for listening.
Okay, our final presentation for this session will be presented by Gabby, Negussie-Retta, and Luann Zerefa. The title is Implementation and Evaluation of an Anti-Oppression Education Plan in Medical School Curriculum. Please welcome them. Hit that button to go forward.
Okay. Hi, my name is Gabby, Negussie-Retta. My day job, I like to say, is the Strategic Initiatives Manager within the Graduate Medical Education at the School of Medicine. And my co-partner today is...
Just say it. Hello, my name is Luann Zerefa, and I'm a medical student here at UCSF.
And we're here today in the capacity of co-chairs for the action group for the evaluation plan for anti-oppression education. So, sorry, let me orient. Okay, so today we're going to talk about the evaluation plan for anti-oppression education at UCSF. The plan was designed essentially to guide our medical educators and the medical school at large in a systems approach that proactively and collaboratively recognizes outstanding anti-oppression education practices, as well as responds to education oppression events as they happen. It was launched in 2023 by Drs. Ariane Tehrani, Denise Connor, and Karen Hauer, and championed and sponsored by a lot of the folks that you will see here. So to borrow a line, we are also a needle in a haystack. So why anti-oppression education? We believe that anti-oppression education is crucial. We've seen time again in research how stereotyping and the lack of representation in educational materials creates cognitive overload for our students, which leads to impaired learning. An example is in dermatology textbooks where they tend to feature lighter skin toned individuals. This leads to physicians feeling unprepared to treat patients and conditions affecting people of color. This obviously has real-world implications for healthcare disparities and patient outcomes. So we believe that by critically addressing race, racism, and disparities in the curriculum, we can better prepare our future doctors to challenge inequities and health disparities, in addition to not perpetuating harm as well. So we also understand that positive education experiences and creating safe learning environments impacts our learners, which in turn has downstream positive effects for patient care. So the purpose of the evaluation plan for anti-oppression education is to foster a culture of continuous growth and improvement. The evaluation plan, which we believe is the first of its kind to really look at anti-oppression student feedback on a systems level using a participatory approach, has three main components. So the first one is streamlining feedback opportunities for our students. The second one is providing timely responses to specific incidents of education oppression that has been identified. And the third one is developing systematic recommendations that we have submitted to the School of Medicine. So we really hope by fostering this culture of improvement and growth, we can empower our faculty to not recognize instances of education oppression, but actually feel comfortable in addressing them in the curriculum, which we hope will improve education outcomes for all of our students.
Right. So, in order to understand how well and what are areas of growth that the anti-oppression practices are in the medical school curriculum, an important factor of understanding that is to capture students' lived experiences and reactions to how the curriculum is best able to support them. Anti-oppression feedback is collected, there you go, both through real-time responses from students through an anonymous feedback form, as well as through routine course and course and educator evaluations. There you go. So anti-oppression feedback both includes exemplary feedback, which are optimal anti-oppression education practices that students have recognized, as well as education oppression feedback, which signals areas where oppression has occurred in the learning environments and students bring up within both the real-time feedback as well as the course evaluations. Right, so in 2023 and 2024, around 24,000 student feedbacks were collected. Those were looked through and seen, and terms related to anti-oppression were discovered. Out of all of those, there are around 1,400 course feedbacks are received, as well as 45 or so through the SAFE feedback form, which is the real-time anonymous feedback. The vast majority of feedback received was exemplary feedback. It really shows strengths that the UCSF Medical School education or curriculum best was able to provide anti-oppression education, and the SAFE feedback form really showed specific points of education oppression. Once feedback is collected, it's shared with course directors who are able to react to it and provide timely responses. A few examples of this include, for example, a case study that utilized reinforced gender stereotypes, so course directors are able to react to that and provide an email to the student body acknowledging harm, as well as what they will do in reaction to that. Additionally, these could be related specifically to educators, and that those points, course directors can meet with those educators, provide feedback and areas of growth to be able to be more inclusive and provide more proactive anti-oppression work. In addition to that timely reactive portion, there's also the action group, which provides more systemic recommendations to student governance. The group focuses on developing these recommendations, as well as engaging in continuous improvement in their workflow of gathering this feedback and being able to respond to it, especially since with all of the comments being received, there's just an immense amount of information gathered. And also taking that, their systemic recommendations and providing it to course governance to be able to further streamline and address areas of education oppression, as well as what the school has been doing great on and should continue to emphasize. Right, so the action group is an important part of that. Gabby and I are here as the faculty/staff member and student co-chairs. And we also have our other board, I don't know how else to describe it really, our group, which Gabby has mentioned already. We have members who are both medical students as well as faculty and staff. We meet regularly and work through the specific feedback from students and how courses have responded to it. And members can be on the board for up to 2 years, and we regularly receive new members, as well as have a course director board that provides additional information as how we can best implement our recommendations. It's really important for us in the action group to make sure that we're able to support our members, provide design justice principles in how we approach our information and content, and work with restorative justice training and practices. Okay. There we go.
All right, so this is our first year, as Luann said. So we're still working on finalizing our list of recommendation, and it's gone through various iterations, and it's now sitting with the Bridges curriculum governance team. Essentially, we have identified 3 key areas. So the first one is on education content. So how is content developed, taught? How is it assessed, focused both on the didactic and the clinical environment? Second one is on pedagogical methods, so how is content taught, and what is the faculty development that supports instructions around these areas. And the third one is really focused on practices, policies, and programs that exist within the School of Medicine to affect that structural change. Sorry, y'all. So these are our final steps. So looking ahead, we're excited to share the recommendations with our key stakeholders, specifically to our students who have entrusted us with this feedback, implement a communication plan, and refine the workflow for our action group. And continuous improvement is at the heart of the work that we do as we go into this second year. So we have the QR code here. You can grab the slides. It also has key terminology lists in there. And this is our contact information if you want to reach out to us. Thank you.
Okay, I'm going to ask all the presenters to have a seat at the table here for audience questions. And then, let's see. Okay. All of the presentations are now open for audience questions. We have them
If you want to raise your hands, and we can bring the mic to you.
back there.
Hi, good morning. Thank you all for those presentations. Very inspiring. My name is Roberto, pronouns he, him. I work with the Center for Community Engagement and CTSI here at UCSF. I've been very inspired by some of what I've learned with regards to how curricula is being shifted, and inspired even by the commitment to an anti-oppressive curriculum. As an undergraduate at San Francisco State, where we've got the only College of Ethnic Studies in the nation, I had the opportunity to be introduced to Black feminist scholarship 30 years ago, as just one example of some of what I got to learn in the College of Ethnic Studies there. And I'm just curious whether we've made any inroads to collaborating with the only College of Ethnic Studies in the nation right around the corner here in San Francisco yet. And if not, what might it take for us to explore deeper partnership with San Francisco State in that way?
Any other hands here? I saw someone.
Is it on?
Okay. All right. So thank you for bringing that up. I specifically thinking about how to collaborate with the action group here with the UCSF School of Medicine curriculum. That is, our group is essentially under the AOCI, the Anti-Oppression Curriculum Initiative, and it's a novel development, as Gabby said. We started last year, and this is our second year, essentially. No other school, we believe, has a group like this where individuals who are students, staff, and faculty of the school can be able to go through this anti-oppression feedback and be able to provide responses to the student governance or to the school itself and be able to work with the deans and other stakeholders. I think we are still figuring out the kinks of how everything fits together since we really don't have any other reference of how best to. But I believe having a group like this could be implemented at other institutions as well. And I'm sure speaking with AOCI governance, we could figure out more ways of building those sorts of connections.
And to add to that, looking at some of the student feedback, that's something we consistently see is to bring in community expertise and voices. And that's something we have also included in our documents.
Hi, everyone. Feels very loud. My name is Samin She/Her. I'm a National Clinical Scholars Program Fellow here with my wonderful cohort. And especially as we're nearing the end of this conference today and hearing everyone's wonderful presentations, everything today, I'm inspired and heartened by the different methods that I'm seeing everyone tackle such important issues with, right? Like we have people who are talking about patients' perspectives. We have people talking about medical school curriculums. And I see the theme of being unapologetic when it comes to confronting systems of oppression, and also the themes of the importance of being inclusive and thinking about the voices that aren't at the table. And as someone who is in a fellowship that is geared towards those questions, it's great to see that work being done. So that was just my side reflection. But the question I'd like to ask, something that I'm reflecting on particularly, is the evolving definitions and the importance of keeping active definitions when it comes to anti-oppression, when it comes to anti-racism. Because while research, particularly at such an incredible and prestigious institution like UCSF, is so important, I feel like a trap that can be had with research is that it lags a little bit behind current movements that are taking place. The one that obviously comes to mind this past year is what's going on with the anti-war, pro-peace Palestine protests that have been going on across this nation, especially on my mind as we're nearing the anniversary of a genocide. And so I would just love to hear all of your perspectives from these incredible backgrounds that you have, is how in your respective fields do you think that this important definition can be included, which is often excluded. And unfortunately, I didn't even hear about any other presentation today that mentioned Palestine as well. So I'd really love to hear that at least once.
I can respond to that a little bit. Thank you for bringing that up. I think it's been kind of an elephant in the room. And I think all of us who, are here for a reason, are interested in health equity and racism and oppression. We're here for a reason, and it's because we care about these things. Interestingly, I think I'll just respond for myself, speaking for myself only, because these are the things we have to say. It seems like this is a process, right? We talk about anti-oppression and we talk about what the difference is between like labels and definitions as they relate to research, but also what this even means like within a healthcare institution. And I like some of the discussions that came up over the course of the conference today around what does it mean to dream what this could be like. What does this, is anti-oppression and health equity, is it an experience? Is it a process? Is it a destination? And I think the questions that you're raising are actually part of the process and part of this experience, as to how we can make sure that, anti-oppression and what that encompasses continues to be inclusive and continues to be powerful. I think your question is part of that process and part of that exploration for us as a community. So I'm just gonna say your question is part of it, and I don't have a great answer, but those are my thoughts.
And I'll just briefly add to that, and again, speaking just as myself, I think one thing that research has struggled with and hasn't made that much progress on is really thinking about how different struggles are connected, how different oppressions stand and hopefully one day fall together. And I think there's talking about anti-Black racism on its own, it's like an intractable, enduring, terrifying, heartbreaking problem. and it is connected to other oppressions. And I think that that kind of intersectionality component is somewhere where, if we're interested in doing research going forward, we all need to do better. So I'm sorry it's not a very satisfactory answer, but I'm grateful for the question.
Thank you to all the presenters for your wonderful presentations. We're going to end the day with Dr. Lukejohn Day. And now pleased to welcome Dr. Lukejohn Day, UCSF Health System Chief Medical Officer, to provide closing remarks.
Good afternoon, everyone. I know it's at the end of the day, so I won't take too long. First, I'd like to thank you for inviting me to participate in today's HERE Symposium. I was incredibly impressed by seeing all of the abstracts, the wonderful presentation, and the really rich and robust discussions that have been happening here today, and even just with the last Q&A. Couple of things. One is I really want to congratulate all of you on an incredibly successful symposium today. As I had walked around, I was just truly awe-inspired by all the work that is being done in the field of health equity and in ways in which we can reduce healthcare disparities for the most vulnerable patient populations. Truly remarkable. I'm very inspired by all of the work that you are doing, and I look forward to seeing the work ahead. I think one of the things that this symposium underscores is really that not only is this critically important work, but that there's more to do, especially in the days, the months, and the years to come, especially in the current climate that we live in the United States. So I would encourage you all to continue this really important work. And then finally, I really want to take a moment to thank all of you personally for attending and participating in today's symposium. Your thoughtful engagement, your active participation, your collaboration, and your really innovative spirit are truly inspiring, not only to me, but to our entire healthcare system. All of you really embody the values and the mission of UCSF Health. I know many of you may not be a part of our system yet, but hopefully we can recruit you to come here at some point. And also, I really want to sort of reflect on the reason why I stay at UCSF. I have never left this system. I've been here for close to 20 years. And it is individuals like yourselves, it is events like these that not only inspire me, but are the reason why I stay here and why I went into healthcare. And so I want to conclude by, again, not only thanking you, but I would continue to challenge you to continue to move forward on this important work. There's still a lot ahead. There is still more to do. I encourage you to ask questions, to think creatively, to challenge the system, and to really move us towards a more inclusive and patient-centered healthcare system. Finally, I really want to thank the organizers and the staff of this symposium. I know it is countless hours of work and leadership and wrangling and bringing people together to make such a successful event occur, and so really want to thank all of them for their outstanding work. So on behalf of UCSF Health and myself, again, thank you all for your participation, and I look forward to having further discussions and seeing more of your work ahead.
Thank you, Dr. Day. So I just have a few items to close out today's session. So I want to first acknowledge and appreciate you choosing to spend your time today with us and engaging in discourse. I think this is just the beginning of a very fruitful, complicated, and enriching conversation we'll have on campus. And we've had wonderful plenary presentations and over 60 poster presentations. We'll be posting video recordings from today's sessions at the ODO website, as well as a booklet of all the abstracts that were presented today. So we'd like to thank the presenters, as well as our reviewers that helped make this event possible. Many thanks to our wonderful keynote speaker, Dr. Monica McLemore, as well as our UCSF faculty speakers, Dr. Catherine Lucy, Dr. Alejandra Ricon, Dr. Vic Fujimoto, and Dr. Nguyen for their comments and engagement today. And it would be not for the executive sponsorship and leadership of Dr. Renee Navarro and the ODO team to make today's event possible. So these are our reviewers who help review the scientific content that was presented today, as well as the HERE staff that you see today and also behind the scenes that have made this event possible. So thank you so much. We'll be sending follow-up information after today's events. There is going to be boba it's coming, and cupcakes outside. So I hope you will join us for a social networking hour at 3 p.m., followed by at 4 p.m. there's going to be a viewing at the Robertson Auditorium on the second floor. Thank you. Have a good day.